that are best used for monitoring and montages, and these are things everybody deals with. It's not unique to monitoring. So I want to spend a few minutes reviewing the properties of electrodes, the types of electrodes, and the 1020 system for localization and naming of electrode sites, because it's as important in the operating room to put the right electrode at the right place as it is in the diagnostic lab. So you've got to at least understand that nomenclature. And I'm assuming everybody has that, so we're going to go through this fairly rapidly. Properties of electrodes are, again, they're a junction between the flow of ions and the flow of electrons. So you want to have materials which can pick up an electron, attach it to an ion, and allow the currents to flow that way. You know, everybody's familiar with electrodes, so I don't want to spend a lot of time on this. The key point is electrodes allow for the two-way movement of charge, and they work pretty well. We've have designed some electrodes which are a little different, but the properties aren't very good yet. They're based on hydrogels and things of that type, and they don't have the good kind of conductive properties that the metals that we used to have. So we think they'll get better, but yeah. Electrode properties are important. Again, it's the simple idea. You got to pick up a charge, you got to move the charge. It's either coming from the tissue into the electrode or from the electrode into the tissue. Goes back to the thing we talked about with charge, movement of charge. So if you remember that conversation, you pretty much have the ideas. And this stuff's all in the notes, so we can skip over this pretty quickly. You know, you want good conductors, low impedance, non-polarizing. You want to establish a good contact. You don't want to have motion artifact from the electrodes. You don't want the electrodes to cause discomfort. So in the operating room, you put an electrode on a patient. It's a different kind of environment. The electrode's going to be there for maybe 6 hours. It can be there for 30 hours, depending on the case. So you've got to pick electrodes which work well, and you want them to be non-toxic, and you want them to be mechanically rugged. We favor these electrodes in the middle, subdermal needles, which is this electrode here, short needles, goes under the skin. We use them everywhere. We use them for EMGs from the ocular muscles. We use them for recording evoked potentials. We use them for stimulating evoked potentials. To us, they're a workhorse. They have very good impedance properties. The negative side is they may cause a little bit of bleeding. If we have a patient that's going to have a lot of electrodes on, for example, for EMGs, we're going to tell them you're going to wake up and there may be some blood on your legs from needles. Don't worry about it. It has nothing to do with the operation on your head. It has to do with monitoring, so they're not surprised by it. A lot of people like to use discs or cups. The problem with them for long-term operations is their properties change. They dry out, and the quality of the signals will change. But the subdermal needles we found, the longest case I've done with them has been 36 hours continuously, and the properties of the electrodes really didn't change over that time. So we become convinced that that's the best electrode to use. Some people like pads and stickers. Again, they don't have good impedance properties. They don't match well with the impedance of the skin, and they don't really work well if you've got sweaty or hairy skin. So I'm an advocate of subdermal needle electrodes, and I think it's the way to go. On the case we looked at this morning, they used EMG recording electrodes, which are, I think they were 2.8 centimeters long and a very fine wire. Those are fine for short cases. For longer cases, I don't think they work the best. And, we will talk about that some more to try to come up with a way to figure out what the best thing to do is. 1020 system, again, everybody's familiar with it, just to refresh the nomenclature. You know, the even numbers are the right side of the head, the odd numbers are the left side of the head. I don't know what happened to these slides, they got a little messed up, but it's intuitive what we're saying. You know, C5 is left side of the head in central location. CZ, today we recorded CZ to A1, CZ to A2. So it's a common nomenclature, and it's important because when you discuss what you're going to do, you've got to have a way of discussing it in a common language, just as you do when you talk about diagnostic data. You need to have a common language to discuss it. So you should, you know, if you're not familiar with it, you should spend some time and just familiarize yourself with the 1020 system. But I think everybody here probably is. Again, just the slide's a little messed up, but the point is obvious. The letter goes with the area of the cortex. The number goes on with the area of the cortex and the side of the head that you're on. Recording derivations. This gets to be a little more important. It's worth spending some extra time on this. People talk about. What's that? People talk about bipolar and monopolar recording. You're always recording in a bipolar mode. So you're always, the reality of recording voltages is it's always bipolar. You've always got to record between 2 points. The question is how far apart are the points, and that's the idea of bipolar versus monopolar. Bipolar electrodes are ones which are close together, and will record waveform when detecting a difference in potential between 2 active sites. So they're close together and they're both active. And if you remember when we talked about the polarity in the electronics discussion, you're looking at the differences between these 2 sites. So voltages, you can have a very high voltage in one site and a higher voltage in the other site, and you end up with a negative result. You can have a negative voltage in the first site and a small positive voltage in the second site, and you end up with a negative voltage. So you've got to learn by practice to try to understand what these bipolar recordings mean for the situation that you're recording. So everybody that does EEGs is really aware of this. People that do low potentials are kind of aware of it. It's the same problem. Monopolar recordings, as I said, you're always recording between 2 sites. So the nomenclature is kind of not good, but the key idea is that one electrode is active and the other is indifferent to the generators that you're trying to look at. So we were looking at CZ to A1. Well, CZ is actually, in that configuration this morning, CZ is actually an active electrode. A1 is a reference electrode for CZ in the way that's laid out. And so it's at a greater distance from the active site. I don't know if that's clear or not, but it's how you're related to the generator. So, very quick run through on this material, which I think everybody has some understanding of. The big difference is between the diagnostic lab and the operating room is the needles really work well. You can place them, you can suture them in place, you can re-staple them in place if it's a long operation. They really are not uncomfortable with the patient. I've placed a lot of subdermal electrodes on myself. It doesn't mean anything, it doesn't hurt. And they're easy to stick into every muscle and record every signal with them. So it makes it very straightforward to set patients up and you're time constrained in how you can set people up. So I recommend that people think in that direction.